My name is Greg Nicandri. I'm from the University of Rochester in Rochester, New York. I'm going to be demonstrating FAST module number 4, suture anchor placement. Before starting the module, I'd just like to talk about the actual FAST workstation a little bit here. This module has a little bit of a fiddle to putting it into place. The first thing that you'll need is the 1-inch puck that you can affix to the station. You want to make sure that the screw holes in the puck line up with the screw inserts in the station. And then when we look at this module, it has a lot of versatility built into it. There's a knob here which allows you to twist this. On the top, this simulates rotator cuff tears, and when you flip it 180 degrees, this simulates labrum and just cancellous bone. There's also another knob on the side here which you can untwist that allows you to load these pucks onto the workstation or onto the module should you need replacements. It's best to do this with it flipped 180 degrees and then rotate the module to the position that you would like it in. And then you need to make sure that this is secure and twisted into the insert. If it's not, if you're using a mallet or any type of punch, you could drive that down in and you would need to restart the task. Then you want to look at these two little holes here, one here and then one on the other side. These need to line up with the holes for the screws that are in the base. You put that down, and then you need to flip the module in order to actually insert the screws into the position. The reason that we screw this down is that if you're using a mallet for a punch or twisting hard to get a bite with your anchor, you can sometimes dislodge the module, and so it's best to have it screwed into the base station. So now we'll make that upright, and then we will twist this around, and we're ready to go. The other thing to know when you're doing this module is that you want these two posts to be away from the side that you're potentially going to be working on so that you don't block yourself with the posts. I'm going to put the clear opaque dome into place, and I'm going to twist this so that the leaf of rotator cuff that I'm going to be working with is going to be directly perpendicular to what I'm going to call my lateral working portal. The instruments or tools that you'll need for this task is a 18 gauge needle. If you're going to use an anchor which requires a punch, you'll need a punch. And then you'll need some sort of suture anchor, and then a ring grasper or another tool to be able to grasp sutures. We're going to talk about the task of anchor placement. I think before we do that, just a quick note on knowing your anchor that you're going to put in. Anchors can be made of various material. They can be plastic, biocomposite, or metal. Most anchors will have a little line, hopefully you can see that right there, that will reference how the threads or how the sutures are traveling within the anchor, either collinear with that line or directly perpendicular to it. And different anchors are different, so it's just important to know which so that you have optimal sliding of your sutures. So for this task, it can be done with or without a cannula in the workstation. I'd just like to demonstrate that these workstation does accommodate a cannula if you would like to practice working through a cannula. And you can do this for the various tasks of knot tying or anchor placement. Because I'm going to be using that portal for multiple things, I'm going to leave it without a cannula for this demonstration. The first thing that we're going to do is I'm orienting myself here that this is a posterior portal, this is a lateral working portal, and this is a anterior portal. So I'll be referencing them throughout this demonstration. So we're going to work through this lateral portal. This is going to be our lateral edge. You can imagine that this would be like the supraspinatus tendon of the rotator cuff. I'm going to take a spinal needle and try to optimize placement. And you want to make sure that this comes in at about a 45-degree angle to the puck that we're simulating. And we're going to insert 2 anchors, one anteriorly and then one about a centimeter more posterior to that. After you've triangulated with the spinal needle, the anchor that I'm using requires a punch. And so we're going to take a little punch and find a spot that's about 45-degree angle and mallet the punch in. These punches are usually lined with a line that tells you where to stop or what your appropriate depth for the punch is. It's important to kind of think about your patient as you're putting these in as well. Sometimes if you have an older patient with more osteoporotic bone, you may not want to sink all the way to the line to allow yourself to get a little bit of a better bite. This is our anchor now, and I'm going to place the anchor into that same hole and then twist the anchor in. And with this particular anchor, we want that line lined up with the rotator cuff to allow for optimal passage and slippage of the suture. And we want the anchor to be seated approximately a millimeter or 2 below the cortical surface of the bone. And we'll pull our insert out and release our sutures. This suture anchor is double loaded. Double loaded means that it's loaded with 2 strands of sutures. Because I'm going to be passing another anchor into this area, I'm going to retrieve these sutures out the anterior cannula. This will keep my visual field clear while we're doing this arthroscopically later. And now I'm going to triangulate for our more posterior anchor. So this one, you can see if I tried to put this in, it would probably impinge upon that hole for the previous anchor. So we take the dial on the fast workstation and give it 1 click. Now you can see that that anchor is about a centimeter apart and in a different part of the rotator cuff, giving us good spacing. We'll punch again. Again, concentrating on being at that optimal 45-degree angle to prevent pullout. Now we're going to place our anchor. In here we're being sure that that line is sunk just below the cortical surface, again 1 to 2 millimeters. Releasing the sutures with kind of a gentle back and forth twisting motion. And now we can give a little tug to our anchor to make sure that it's not going to pull out of the bone and not going to fail, and that it's well seated. We can make sure that our sutures slide appropriately, and we would be ready to proceed with our repair. Okay, we are now going to demonstrate anchor placement under direct arthroscopic visualization using the opaque dome. Before we put the dome on, I just wanted to make mention of a couple of things about the module. You can see that we trimmed off some of the simulated cuff here to shorten this, just to give more exposure of the simulated tuberosity so that you can better visualize where your anchors are going to be placed. The other thing that's important to note is if you're going to use any anchor that involves a punch, you want to have this little twisted knob on the side that you're going to be punching to offer additional support so that you don't knock the inner portion of the module down. For anchors that do not require a punch, this is not as important. I'm going to go ahead and put the opaque dome on. To orient for portals, I'm going to use this as a posterior visualizing portal. This can be a lateral working portal, this can be an anterior working or suture retrieval portal, and this can be an accessory lateral portal here. So the scope is placed posteriorly. We'll now orient ourselves so that we see the lateral edge of the simulated rotator cuff. I'm going to take my spinal needle and try to figure out where I would like to make my accessory portal. So using our lateral portal, you can see that this probably will come in at too low of an angle. And so we'll come up here to try our accessory lateral portal. If I place it here, this is probably too steep of an angle. If we come here, we're going to try to optimize at about a 45-degree angle. So I like that position. Then we can look over where we are anteriorly. I think we'll move it back just a little bit here. And I like that position. Now we're going to insert our punch, and again visualize to make sure that we have the angle of approach that we like, the position on the cuff that we like. We'll have our assistant tap this home. If you don't have an assistant, you can also do this using the IPEVO camera. For this, we're simulating osteoporotic bone, so we're not going to drive it directly to the laser line. However, in somebody that had very good bone, you would put this all the way to the laser line. Place the anchor in at the same trajectory. You want to make sure that you get it set to the appropriate depth, again 1 to 2 millimeters below the cortical margin, with the laser line aimed anteriorly so that it's perpendicular to the edge of your simulated rotator cuff. That will allow your sutures to glide. We remove the anchor, and again you can check the anchor by pulling up. You can see that we've got 2 sutures that are anterior and 2 sutures that are posterior. If you look at how this anchor is made up, you can see that the suture eyelet that the anchors slide through is lined parallel with the cuff, and that the sutures easily glide. And we're going to place another anchor more posteriorly, and so we're going to retrieve our sutures out in anterior suture retrieval or suture holding cannula here. And again, we're going to do the same thing. We're going to insert our spinal needle through the accessory portal and see where we would like to place our suture. If we don't exactly like the access that we have, you can always move the dial on the workstation. This is like internally or externally rotating the arm to give you better exposure. And that looks like about the position that we would like here. So again, we try to get that 45-degree angle, and we'll tap this home. And again, we're going just short of the laser line in this model, but in somebody with good bone, you would go and seat it fully to the laser line. We're inserting the anchor again. Here we're at that cortical margin. We're going to go just below, probably 1 full turn, perpendicular to the cuff. Pull this back, give your anchor a little tug and make sure that it's sitting in there appropriately, and again you see that those sutures are going to slide appropriately. Go ahead and give me a tap to get that started. Good. And we're going to twist this in. And again, sinking it below the cortical bone, making sure the line is perpendicular to the edge of the tendon. looking at the anchor, making sure that it doesn't pull out, and making sure that our sutures move freely. So now we're going to show a little bit about what not to do. So this is us inserting the punch a little bit too far. And we'll insert our anchor through that. You can see that this goes in relatively easily. If we give it a little tug to check on the anchor, you can see that the anchor pops right out of the bone and pulls out. A rescue for that in real life would be then to upsize your anchor. Say if you were going to a 5.5 or you were using a 5.5 anchor, you could upsize to a 6.5 and see if you could get a bigger bite or a better bite that way. The next error we're going to demonstrate, we're going to make a little punch over here. We're going to insert our anchor, and when you're doing this in the real situation, you often have blood and tissue and not as good visualization of the cuff margin. And so sometimes when you get down here, you have a little bit of rotator cuff and you're not able to see the actual tuberosity, or you have soft tissue on it and you wonder whether or not you're all the way down. One way to check that is to back this out. You see where the sutures are coming out. At this point, you can still reload the anchor and drive it down further. If you were to do that by taking it all the way off at this point, we would not be able to then reload the sutures onto the insertion handle. If you try to go down here without the sutures in the insertion handle, you can't get in this little square to twist this down any further. So if you've left this proud, you've really made some significant work for yourself if you want to try to rescue that. So the key is to back up slightly while the anchor's still, or while the insertion handle is still on the line of sutures. Visualize where your anchor is in bone. If you like it, then you remove it the rest of the way. If you don't, you can slide it right back down the sutures into the slot. So we have now changed our module slightly to one that more simulates anchor insertion in a labrum. You can use another type of anchor where you actually have to drill into the bone here, which is simulating the glenoid face, and then you could pass sutures around the labrum at this point. This is the same module that we had previously, just flipped and rotated upside down. We're going to do this under arthroscopic visualization. We're going to use this as our posterior viewing portal. We've got a high anterior portal here and a low anterior portal here. We'll take our spinal needle to again get a good trajectory on our target. And this is our glenoid labrum. This is our simulated glenoid. We want to have our anchors onto the face of the glenoid. Typically we'll start at the inferior most position, and we're going to try for a 3 anchor repair here. So we would put one anchor here, and another anchor here, and another anchor up here, and all seem like they would be able to come through that low portal. We'll place our percutaneous drill glide. This does have an inserter on the inside that you can use to get through soft tissue. You can remove that, and then this goes on to the glenoid face. We're coming down here to the inferior margin, and again up on bone. And now I'm going to have an assistant drill the anchor. And I always tell folks when putting in these anchors that you want to do this with the drill on at all times to decrease the amount of friction in the drill guide, especially when pulling out. This has a hard stop on it. He's got the drill on as he comes all the way out, again, so that the friction doesn't take me off of the glenoid face. Now he's inserting the anchor into the drill sleeve, tapping the anchor down, and there's a pre-marked laser line here that goes flush with bone. Good. Now he's testing the anchor by pulling up on this. And our anchor and our drill sleeve can come out. And we'll retract our sutures out of that anchor so that we have a clean cannula to work through. So now we're going to come up slightly more proximal. And place a second anchor. Usually leave the outlet in the drill sleeve so that we can visualize the drill coming down into bone, going all the way to the stop and coming all the way out on power. Giving it a little tug. You can see that this more simulates osteoporotic bone and the anchor pulled out. So that anchor pulled out, as it might if you were doing this in somebody with poorer bone quality. If that occurs, you can choose a slightly bigger metal suture anchor and come in the same trajectory and then screw that into place. Again, down to the laser line. If you give that a little tug, that's got much better fixation within the bone. And with the last one, we're going to demonstrate one more time an example of what not to do. I'm going to retrieve these out of our suture saving cannula. Placing this onto our glenoid margin. He's going to allow the drill to stop, and as he pulls back, it will pull my drill guide up off of the bone. And then you have to fiddle a little bit to find the spot again to put the anchor back down onto. So it's best if the drill stays on forward until the person gets all the way out to decrease that friction. Pull on this one stays in.